Good morning and welcome to our monthly webcast. This is session number 115. I am your moderator Samir Mehta.
And this is a 86-year-old female who actually had stable angina for many years and has a documented ischemia a few years ago, but did not want to go for cath, was put on a maximum medical therapy. Now because of a little more symptoms, the patient underwent cardiac catheterization at outside hospital, which revealed left main and two vessel disease, which will show you calcific, and there is a focal aneurysm of the LAD, and patient was recommended cabbage. So Anu, you want to just take us through?
So this is the LV function. EDP was normal EF, and right coronary artery essentially normal. Some moderate disease in the mid RCA, mid PDA, anterior takeoff. We needed AR2 to engage it. But this is where we are with the left main. Definitely calcific distal left main, and we took several pictures to exactly see the ostium of the circ. But what you see is that aneurysm probably coming from the left main itself. You see there? Here was not clear, but in the cranial view, it's probably coming from the left main, and then you have the mid LAD, another 80–90% disease. But
it's a very
every view,
I
think the circ is okay.
The idea would be that we put a stent across and aneurysm will fall down. So here what will happen is we have to see what's happening with the ostial circ. Once you put a stent across from the left main to LAD, aneurysm will become 1/3 the size. What happened, because there is no flow, it just falls on it.
Right. Anu, the lesion in the proximal to the mid LAD also looks to be severe?
Yes.
That always was, yes.
Not calcified, but significant disease. So what I would suggest that we would go with 175 Burr, just take care of the left main with 175 Burr, and
provisional crossover
stent across.
The basically when patient was seen just about 2 weeks ago, was started on aspirin, otherwise was taking metoprolol, torvastatin, apixaban, isosorbide and ranolazine, and aspirin was just recently added to the regime. Overall syntax score is 30. Again we have to see that Medina was 111, and today is complex intervention of the calcific left main, bifurcation using rotational atherectomy, and planned one stent crossover technique with IVAS guidance, one stent technique because the fall risk, potential, depth interruption. So single stent is the one we want to do in this particular case. Let's just quickly go through the 2 points, and that 2 points basically we always talk about FFR during PCI, but we are talking about now FFR during angio in the cabbage. So data of FFR guided versus angio guided cabbage. And the second is the temporal trains of OC categories in PCI. Okay.
So essentially it is coming from the distal left main, the aneurysm.
Anu, the problem in the wire, was it it's coiling in the aneurysm?
Yeah, coiling in the aneurysm. That's why I went to this view. You see that?
Yeah.
So it is coming of the
circ looks all right, no?
Yes, looked all right. So that's why the wire went easy now when I came to this view into the circ.
Right.
This is how you see that the wire went okay.
Yep.
So I needed fine cross, or you need a balloon support, so that you are able to navigate through the.
You're wiring the circ to IVAS?
Yeah. So I thought let me do the IVAS.
Okay.
But IVAS catheter is not making a turn. It could be because significant disease of the left main, calcium, or the aneurysm.
But question is, do you need a supercross to make a turn for the LAD?
No, what I'll try again, same fine cross, and we'll go with a miracle with an acute angle and see. If not, then you have to use a supercross.
So now we are trying to make a this is miracle 6.
Miracle 3.
3. Okay.
Have the 120. You think if you need it?
Yeah. Get
supercross ready.
Supercross 120.
Okay.
So
now
we go to other view. Which one?
Cranial. All you needed was a
little stiff.
Acute curve with a stiff, which is this is a miracle 3 wire. Okay, some dye. So now I'm in the LED.
Ready for IVAS? We are going to do IVAS soon.
So
get
no,
the
what I
extend
want to
length wire.
do is change to rotawire.
Yeah. Okay.
And we'll do IVUS on the rotawire,
You want to do IVUS on the rotawire?
100%. So with the fine cross, this is the picture we took, and this is how we know.
Which is
See how
what-
the LED is actually coming from the aneurysm. So you have to enter the aneurysm and then make a acute turn.
And the wire would be coiling in the aneurysm also.
Yes,
Yeah.
yeah. That is why we were selected that you need a little stiffer wire that you are able to make that acute turn.
And
you want to show what the curve we made.
Samin had observed about using the supercross too.
Yeah, otherwise if this has not helped us, then would have been a supercross. This is the curve that crossed, if you can show it.
So, while we are having a discussion, which yes, the point is what are we going to do different?
So this
These
is a mid
aneurysms are
LED
left
lesion,
alone, yeah.
right?
Yep.
So we got to stent right from there. So bookmark there and give us a cross sectional area, okay? Yeah, there give us a cross sectional area, and now we are coming towards the
Yeah, look at
Left
that.
main.
yeah,
Okay.
yeah. This is the LED. LED ostium. Can you see the aneurysm? That's aneurysm, right? And then we are coming towards
No,
the.
aneurysm has not come here.
No, that was what it was.
Yeah.
There you go.
This
There
is
we
it.
go. Yeah.
Okay.
Yeah, so it's actually at the distal part of the left
Septum.
main.
Right.
Distal left main.
Yeah.
No, that you cannot say. Distal left main heavily calcified.
Yeah.
360-degree arc of calcium. Maybe that's the reason we did not get into the circ, right?
Yep.
Okay, we can stop. We have 175 bar opened.
And what balloon we have?
We have a 3.0 for the mid LED and a 3.5 for the left main.
Okay.
And a cutting balloon if we need, we have
4
standby.
of is a Wolverine, yeah.
Oh wow.
Went easily. huh?
175 bar did nothing.
Yeah.
What was the cross sectional area of the left main?
You're just at the
The left main was 3.6, so truly narrow. Yeah.
Okay,
That's it.
good.
Yeah.
Would you contemplate a larger burr, although now
Don't give
the-
that.
you
Don't give
you
that.
have a 6 French guide, so
Yeah.
Okay, I don't think you need a larger burr.
okay.
Yeah. I would say this is the kind of case you'll couple with, and that is where the whole question came down to, that what's the wrong with Impala. I would say this patient a little younger, no issue about the dual anti-platelet therapy, not issue of the NOAC. I definitely, it's appropriate do the Impala. Now, Impala has advantages, but same thing, higher vascular complication. So that we need to be worried about. So that's the reason we did not use Impala in this particular case. Now rest of the technique is the same way as we do a packing motion back and forth slow and decrease in RPM. As I mentioned, be careful that it's a very low resistance of the advancer. So you have to just let the burr go, don't push it through, because we saw that a few months ago when we had the burr stuck because
Right.
it went a little too easy. So very important, but all these changes are going to happen soon to our advantage, making the whole assembly much simpler.
Any use here or intention to use the cutting balloon further, or
Yeah, let's see now. So you want to take a picture or you want to put a wire again?
No,
Different
we have to
wire?
go with the fine cross and change
Okay.
it. Remember, this
Get
is
the
not
fine
a case
cross.
where you can go side by side.
go.
Go. Nice. Okay, give us the fine cross. We have the long run through. We use the same one. Yeah. And then, no. So what we will do, I think we'll go with the regular balloon.
No, high pressure you mean?
Yeah, high pressure means
Yeah.
means not
Yeah,
cutting
same
balloon.
trio.
We just go with the NC balloon.
Yeah,
But you
And
want to
see
do
how
the left
things
main
are.
first, or you want to do the mid LED first?
mid LED first?
mid LED first. Yeah.
Okay, then it will be 3.0. You don't
yeah.
want 3.5.
You trio.
Okay, get us a 3.0. What
Yeah.
you have? 15? Yeah. See that the dye staining is in the aneurysm, right?
Let's see.
Yeah,
Okay,
yeah,
I'm doing
yeah,
little
yeah,
dye.
Yeah.
It's
See, that's
aneurysm
an
versus
aneurysm.
distal left main both.
No,
yeah.
it is aneurysm.
Okay.
Okay, so go up here.
That's
This is a
the
12.
3.5.
3.5, 12.
Why didn't you go 4? Okay.
No, we said we are not.
Okay.
Okay.
4 if need to, we will go to the cutting balloon. So clearly, you want to magnify? Yeah. So
Still
there is a
there's
dent
little
there.
waste
See?
there.
Yeah. So I'm going to 20 atmosphere.
Good.
Opened up.
Opened up.
Open nicely. So that is the key.
Down.
Rota, cutting the eccentric. You are going to go back again. That eccentric little cut, subsequent balloon facilitated PCI. So really have plaque modification. Ready?
I don't think you need 4O, we can direct stent. Question is what
Two
should be
separate
the
stents.
stent size?
Two
Oh,
separate
two
stents.
separate
No,
stents.
two separate stents.
Question for you, would you want to wire the circ now?
Yeah, we'll try that. Let's do the LED first. Let's finish the LED after the diagonal. You want, because of the dual antiplatelet therapy issues and all that, in this particular case, shorten the duration like senior trial of 75 years of age. You can even stop after 1 month, which was better than bare metal. So I would say we go for synergy in this particular case. So let's get our 3024 synergy. So now, so as I said that we are right now dealing with the mid LED.
So you see that diag, just after the diag we'll place this stent.
Go. One of you can remove the rota. We don't need rota. IVUS will need.
At the end.
Yeah.
Okay. Some diag.
Oh, sorry. 20. Just little die.
Yeah.
Good.
Nice. Okay, go up. See, even that caused a little dissection, right?
Yeah,
Is
that's
it 3.5?
3O.
30
3O 24. Synergy.
for 16 atmosphere. Keep floor up. Right now, then become black. Yeah.
Okay, good.
Yeah. Let's get which wire you want for the circ.
I think the run through went. Give me the short run through we had. Okay, you want to take a picture? Quick picture, document. That we are good.
Low mag.
Yeah,
Good,
nice.
beautiful. Now
Okay,
see,
I think it was
earlier
all
IVUS
left
could
main.
not go, and now your balloon. You want to do a little balloon dilatation?
Absolutely. I knew that you were going to say it.
Okay.
That's the reason I
In,
asked.
in our own
No,
situation, I can tell you that we've been showing unprotected left main now for about 7 or 8 years.
Yes.
Through IVUS?
Yep.
At least I think 25% of our cases, where a lot of them, the similar case 5 years ago, it was always done with a balloon pump or sometimes with impella.
Okay.
Yeah, that's right. So, but the ejection fraction for us is the combination of lesion complexity and the balloon pump.
We are doing IVUS again of the
It-
circle.
Yeah, now we are trying to do IVUS of the circumflex, and just want to let everybody know that while we are thinking about talking about the left main as a standard now, of course, because I would say that Park from Korea has a lot to do, bring it to the main stage and subsequent trials and so on and so forth. 1998, and Samir, you remember, in our first CCC symposium, we did 3 unprotected left main. One case was the aortic dissection, which we did from the right brachial. We didn't have radial that time, so the brachial approach.
Cut down.
Yeah. So we did 3 in 1998. We did 3 live cases of unprotected left main. Oh, good. All right. Let's start.
No disease. Now we are coming to the ostium soon.
No,
This is
far away.
proximal.
Yeah.
Proximal.
Okay.
Okay, this is ostium. Okay, this is aneurysm.
So not
No disease.
minimal to nothing. Yeah.
Okay, that is what we
So
discussed.
that
So
provides
now
the
aneurysm
rationale
we have
for
identified it is in the left main,
Yeah.
at that angle of the LED and left main.
Where ramus should be coming, instead of the ramus, we have an aneurysm.
Yeah.
That's what it is. Yeah. Show us exactly ostial circ and give us a cross-sectional area. Cross-sectional area including the aneurysm.
Okay, which we will put a stent now. The left main. Is this okay? Keep it one side. Let's get to the wire.
Yeah, yeah.
9.23. Okay.
Okay, we are taking the picture, and our X-ray guys are there or they're on break? They're supposed to come and fix the machine, right?
No, not now. Later on. Stop it.
Did they know about it or no?
Yes, yes, but not now. We cannot come. They cannot come inside at this time.
Yeah.
Good
Okay,
view
now you
to-
see it now. Very clear display. We have the wire into the circumflex. There is a large aneurysm from the distal left main into the LED. Yeah. So now my question is, let's think about, no, before we go in, there is a little disruption of the proximal LED. I think we need a longer stent. You make it a 4020.
No, 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 no.
Yeah. Why?
See, you have to give a gap, otherwise you will be double layering the diag and you'll close the diag. Okay, that's a big diag there.
Okay, then just do this. If need to,
16.
we will decide. Yeah. If there gap, then leave it. We'll deal with it later.
Let's
Yeah.
see.
Go.
12 will cover it,
Right.
otherwise have a 16 ready, 4 or 16 ready.
Yeah, possibly 16, no?
Yeah.
No.
And we are going to show that this aneurysm is going to almost disappear after stenting.
I'm not that confident
Go.
using synergy that
Yeah, I
the
think it
aneurysm
will
will disappear.
decrease, but let's see if it decreases substantially. Samin, you want to, okay, let's pro.
Did we dilate that LED?
No, we didn't dilate
Not
it.
at
Yeah.
the,
Problem.
not at that
See?
origin.
I think we just focused on the left hand, but with that was a 12 balloon, no?
Yeah.
Okay, show some dice so
What
that
4
give us
balloon
an
we
idea.
have? Get the 4 balloon.
oh, wait.
Oh, that balloon again. No, it went in. Yeah.
Oh, you want to take a
We have
wait.
3.5.
Okay, picture.
Yeah. Make sure it's fully covered. Yeah. Proximally. Proximally we have to cover. If need to
Okay,
put
okay,
one
okay,
extra
16.
stent, will be okay in the mid. Good.
Covers
Very good.
Very nicely. I
Ready?
think.
Wait.
Yeah.
Not ready. I want to go in a little bit.
No, why? Okay.
It's too much in the
Okay.
left
Yeah,
main.
1 millimeter
That way we
fine.
are
2
all
millimeter
covered.
good. Yeah,
Yeah.
2 millimeter okay.
Okay, now die. Yeah, good. Go up.
Ready?
Yes.
Okay. This is a 4-0-12 synergy. Synergy going to do the magic.
Okay.
Anti-aneurysmal or aneurysmal obliteration stent.
Who votes that it will go and who votes that will not?
I can tell you aneurysm will become less than 50%.
Okay. Anu,
Less
what-
than 50%. Okay.
Okay.
See it to believe it. Let's go for it.
Still there. Okay. Went
Let's
down
see.
by 25%.
Yeah.
No, this is almost half.
25%.
What do you think,
No, I would
Samir?
not.
I think
4-5.
I mean it's
Absolutely will
reduced,
not
which
go
is
for
what the
5.
aim was.
Yeah.
What about the area in between the two stents?
Yeah,
you
we'll
think?
take care of that also now.
Yeah.
Now we need to take that wire out now. Take the wire out.
Oh,
before-
yeah.
Yeah,
Okay.
always before you go to high pressure, of the side branch wire should be removed. If you want, you can rewire it through the stent studs. But otherwise, before very high pressure, you always should practice of
Okay.
removing. Ready?
Yeah. Now we are just at the level of the distal left main and aneurysm.
Aneurysm, yeah.
Yes, good.
Yeah, this-
16. You want to go more higher?
No, down. Okay, now here, ostium.
Yep.
So we know we are nicely. Wait. We are there. Okay, go up here.
Now I was supposed to get stent
Enough,
boost in this.
Enough.
Yeah.
Beautiful.
Go to
Yeah.
epicranial for that mid segment.
Okay,
I mean intervening segment.
go. Epicranial, let's take a picture.
What do you want to do? It looks very good. You want
I
to do
would-
IVUS?
We'll IVUS, but
Yeah.
we are not doing any more
Good.
massage or stent,
Okay.
balloon.
for
nada.
the mid portion.
Yeah, aneurysm is 25 millimeter. The
So we are
aneurysm-
going from left main to LED. Okay,
Yeah.
guys, repeat IVUS. Okay,
Yeah.
start. This is the mid LED stand.
Looks
Good.
nicely opposed.
Yes.
Good.
Area in between. Now the stent
Fluoro.
edges come back. Nice, good. This is
Yeah,
in
nice
between.
Newman.
Looks good.
Little-
No dissection.
A little bit.
No.
I thought there was a little intimal flap
Yeah,
at
yeah,
the
yeah,
very
that
dis-
was-
That is part of PTCA.
We'll remove it,
Healthy.
yeah.
okay.
This is
And
left main.
Left
well
main looks
opposed.
excellent. No problem with the left main.
Good.
So you are intending to leave that alone, and we are
Everything to be left alone.
Yeah.
okay.
So what we did, you take 4O stent and you deploy at 10 to 12 atmospheres across left main to LED. And then what you'll do a shot, we took a 8 millimeter, 4.5, and you go high pressure of the proximal part of the stent, which is the left main. So you know it is well opposed, and that was confirmed by IVUS. So pot was done here. And also what we did, pot was to make sure that stent is well expanded at the level of the aneurysm, hoping that aneurysm will gradually collapse.
Anu, excellent case to start the new year. I want to thank all of you for making it interactive, and we'll see you February 19th for session 116.